So contractile reserve is the change in the systolic parameters, the common systolic parameters of TAPC, RV fractional area change or S prime following the induced stress, and which is a compensatory movement or improvement of the heart function during the cardiac stress. However, despite a lack of the clear criteria for RV contractile reserve in the guidelines, there is some prognostic implications or significance of measuring the contractile reserve. For instance, a decline in the RV S prime of more than 4 mm during exercise has a reasonable sensitivity of proximal RCA obstruction. Similarly, a TAPC of less than 19 during the exercise implies that RV dysfunction that is associated with a poor prognosis in primary MR. Stress-induced pulmonary hypertension is another entity that is defined as pulmonary hypertension that happens only during induced stress, and it can also be deemed as an early stage of pulmonary arterial hypertension. And it also provides a better prognostic value because we can institute treatment early in the patients of pulmonary arterial hypertension, particularly like estimated PASP of more than 60 during a stress echo has been reported to be a predictor of poor clinical outcomes. Contrast echocardiography is another modality which can clearly visualize the RV endocardial border and allow for a more accurate assessment of the RV dimension and regional wall motion. And when it is combined with a 3D RV assessment, provides a better comprehensive structural as well as functional assessment of the RV function. And in cases of coronary artery disease or RV cardiomyopathy, this contrast echo, myocardial contrast echo has got a unique advantage or edge to able to visualize the right ventricular perfusion also that cannot be detected by other echocardiographic modalities. So assessment of perfusion is another plus point with this contrast echo. The problems are with workflow issues in the like intravenous cannulation is required. There is potential for artifactual errors and lack of standardized normal values. Regarding speckle tracking, we know that the strain imaging or speckle tracking is more sensitive. Thus, it can detect the subtle RV dysfunction that cannot be revealed by the conventional echocardiographic parameters like RV, FSC, TAPC or S prime. Because, speckle tracking echo could be less load dependent. It does not depend upon the preload in comparison to the other conventional measures, and it focuses primarily on the myocardial itself rather than the volume change. So, it is volume or pressure independent changes. These are showing some, speckle tracking echocardiography showing normal values, 3D speckle tracking as well as 2D speckle tracking when it is combined with the fractional area change measurements, and it is speckle tracking when it unmasks the right ventricular dysfunction. You can see in this patient by 2D and 3D speckle tracking echocardiography, all 2D speckle tracking derived parameters in comparison to the previous images showing lower values where the TAPC is low, the ejection fraction derived by 3D speckle tracking coming out to be only 38%. So RV strain imaging has got some additional advanced parameters. There are particularly two methods to assess the longitudinal strain. One is the right ventricular free wall longitudinal strain and one is the right ventricular global longitudinal strain. The free wall longitudinal strain is based on only the RV free wall assessment of the strain, whereas GLS, as we all know, it measures the global strain of the RV and includes the interventricular septum also. Normal values also differs between the parameters. However, the American Society of Echo and the European Society of Cardiovascular Imaging, they recommends reporting primarily the free wall longitudinal shortening over RV-GLS, probably due to more standardization or standardized value of free wall longitudinal shortening. Now, what are the clinical implications? Implication is that this longitudinal strain can reveal an early stage RV dysfunction and can be useful as a better prognostic indicator. For instance, a free wall longitudinal strain has been a better predictor than TAPC for PAH related clinical events. That is, whether the patient will be hospitalized or requiring a therapeutic interventions for pulmonary arterial intervention. There is a much better predictive value with the use of RV free wall changes, and also it has got a mortality predictive value also. RV strain, there is numerous advantages like being angle dependent. It provides not only global assessment but also a regional assessment of the strain, and it can be helpful in differentiating etiology of the diseases like whether it's an ASD, ARVD or other cardiac amyloidosis. Regarding 3D echocardiographic assessment of the RV, it very accurately measures the RV ejection fraction and almost it is corroborative. Yes, I'll take only one minute extra. It's almost corroborates with the CMR derived measurements of the RV ejection fraction, and because of the unique crescentric geometry of the RV where 2D has got significant limitations in measurement of RV ejection fraction, the 3D echo can pick up the RV geometry, patterns of RV remodeling and hemodynamics and also the RVPA coupling, and it corroborates with the outcome. The last part is the future perspective, probably in echocardiography, the right ventricular PA coupling, which is conventionally done by the invasive measurements using the end systolic and arterial elastance, which is a sensitive marker of the RV dysfunction, which starts before the EF deterioration or RV dilatation is observed. And non-invasive assessment of the RV-PA coupling are also now being assessed. TAPC by systolic pulmonary arterial pressure is a surrogate marker of this RV PA coupling, and also stroke volume by end systolic volume is another indicator that could well correlate with the invasively measured measurement of the EES by EA ratio. So these are non-invasive assessment. Now regarding cardiac magnetic resonance in RV, and I'm not going into details of this, already has been exhaustively discussed. Regarding myocardial tissue characterization of myocarditis, sarcoid, infiltrative diseases, it is the gold standard, along with assessment of the volumetric assessment of the RV. Probably the 4D flow MRI, which is the future of non-invasive vascular imaging, that enables not only the structural and the functional assessment, but also accurate assessment of the vessel, the transvalvular or the intracavitary flow, provides a comprehensive description of the flow changes in the pulmonary circulation also. And it has been utilized to identify the abnormal flow patterns in the male pulmonary trunk, which are correlated with the mean PA pressure, making its estimation possible. It is also utilized for characterization of the physiological vascular parameters like the shear stress, which affects the vascular remodeling and typically reduced in pulmonary arterial hypertension. Radionuclide imaging in certain selected cases like before LVAD implantation, right ventricular, in CMR incompatible, where it cannot be done because of some implantable devices where radionuclide imaging can be done. The uniqueness is that it can also assess the myocardial metabolism. So in summary, assessment of modalities of RV failure includes ultrasound, CMR, radionuclide scan and the invasive measurements. However, there has been some knowledge gaps, there has been some pros and cons of each modalities, but the future direction includes among the echocardiography the contrast, trace, speckle tracking and the 3D echo. Among the MRI, possibly the artificial intelligence augmented MRI assessment, the hybrid imaging modality using this perfusion or nucleotide scanning, assessment of the metabolism also. And this is the simplified algorithm that how to assess the RV dysfunction using its volumetric analysis, the pressure measurements and also the assessment of the contractility. And finally, with the use of these advanced modalities like MRI, the radionuclide imaging, the catheter based imaging and finally the advanced catheter assessment to confirm the right ventricular failure. Thank you very much.